Hello and good evening, everyone. You're very welcome to Understanding My Migraine, episode 4, where we'll be discussing migraine in menopause and perimenopause. This evening, we are very grateful to be joined by Dr. Mary Kearney, who is a GP with an extended role in headache and migraine. Dr. Kearney worked primarily as a general practitioner in her own practice in Dunlavin in County Wicklow, in consultation with Dr. Martin Ruttledge and Miss Esther Tomkins from Beaumont Hospital. She was lead author of the publication Migraine, Diagnosis and Management from a GP Perspective. Dr. Kearney is a member of the Cochrane Collaboration as a result of her being lead author on Cochrane's systematic review on a rare neurological illness. Dr. Kearney has done a lot of work and talks for the Migraine Association of Ireland previously, so we're very thankful to be joined by you this evening, Mary.
Well, it's a great honour for me to be back here this evening and to have the opportunity to talk about migraine in the perimenopause and the menopause, and hopefully in the long result to be able to help people with migraine during those times. And really what we have found over the years is that really and truly there's a lot to be learned and a lot more to be done for people at this particular time in their life. So thank you very much also, Cy, for that lovely introduction. And as Cy said, I was in general practice for more years than I care to admit to, but anyway, in Dunlavin for over 20 years. And I enjoyed my time extensively, but an opportunity arose to step back from full-time practice and I took it. But suddenly I found I really did want to do something. So then I've become involved and upskilled in the area of headaches. I've no financial interest in this presentation, and the information is presented is accurate as of now. And as we find with all things, very soon after you do them, they become slightly out of date. And we've already heard from some of the previous episodes of this that migraine is a huge problem. And for me, the fact that most, like 42% of all women will have had a migraine sometime during their life, even 10% of the population. So it's a huge problem. And for me, the saddest thing is that it's the highest cause of disability in this age group between 15 and 49, when women are at their most productive between education, going out into the world, maybe getting married, starting a family, caring for elderly people. So it's really a very vulnerable time for them. And when you look at the extent of the problem, you find that it's second to back pain. And we all know how common back pain is. And these are not just Irish figures. This is from the World Health Organization. And women lose so much time from work because of migraine. And some of it, I think, could be avoided with better care. And that's where I hope I and SIVE and of course the Migraine Association over the years are well able to help. This evening, we're really going to talk about a couple of areas, the hormonal areas. And while it's focusing mostly on the perimenopause and the menopause and the postmenopause, in order to understand what's happening at those times, we need to look at what's happening during the women between 18 and 35 so that we can understand the changes that occur at other times. We're not going to focus on breastfeeding or pregnancy at this stage or the younger boys. So just let's maybe have a think first about the menopause and the different stages. So perhaps if we start here, the menopause is here, and then you have the postmenopause. And this is the perimenopause. And before that, we have this age group between 0 and 35, where we call it the premenopause. But the perimenopause is the age between we'll say 42 or 3 and 52 or 3. And that's the age that really the problems arise because the hormone levels are just dropping and they're fluctuating. And that's what really causes the problem. So just to recap for a minute about what age are you more likely to get a migraine? And you can see here the graph is going up. So you're more likely to get a migraine in those teen years. You're slightly less likely to get it in your 20s, but lots of people do get it in their 20s. But then as you approach 40, the age goes up again. So you can see there is an increase in those even getting migraine as you approach the menopause. And it's just worth bearing that in mind, that some people, you know, migraine does change, and perhaps coming towards the menopause, you might get it, but it might not stay too long. So as I said before, we need to look what happens in the pre-menopause time. And, you know, generally speaking, people say that the menstrual cycle is 28 days from the start of one period to the start of the next period. However, most women will be able to tell you, well, really, my cycle was never regular. But for a lot of people, it's between 26 days and maybe 32 days. However, there's 3 different ways migraine is affected by the woman's menstrual cycle. And we'll just look at the menstrual cycle here. Here's day 1, and here's the ideal day to 28. And this is what the estrogen level is doing. It rises in the first half of the cycle. It drops a little bit at ovulation, just in the middle, but really the drop is not too bad until the next period is expected. And there's where the drop happens. So it's in those 2 or 3 days just before the period that really and truly you find the migraine, the menstrually related migraine, or the pure menstrual migraine comes on. And that's when the problem starts for those people. And of course, this is the hormones here. This is estrogen, even though it's not spelt the same way as in the previous diagram, and it shows it rises there. Now, this diagram gives a slightly bigger drop here than I would have had, but you can see it's not sustained. And in actual fact, the best estimate is it's here. We'll also be talking about this green hormone, this FSH. And as you can see, it rises a little bit in the beginning of the cycle. It's at its maximum here. And we'll discuss the functions of that very shortly. The progesterone is the other one. The progesterone here, it's fairly stable until you come to the second half of the cycle. And the LH is the least talked about hormone, but it's at its maximum just at ovulation. So we all have an idea what estrogen does, and it has a lot of functions in the reproductive area. And as the estrogen level rises, the FSH level falls. So when the estrogen level then rises, it causes a surge in the LH. This is the other pituitary hormone. And then the LH surge causes ovulation when the egg is released from the follicle at day 14. But the estrogen does target other organs other than the uterus. And we're all well aware of the bone and the dangers of osteoporosis in the postmenopausal area time when the estrogen level is reduced. And during the menopause, people kind of do say sometimes, or certainly perimenopausal, that they're a little bit forgetful. It also has an effect on the heart, so much so that maybe 20 years ago, there was a vogue whereby people were encouraged to take hormone replacement therapy to help them with heart disease. However, that has since changed. But it does affect the skin, the breast, and the liver. So what happens to the hormones, as I showed you in the initial slide there, they're all up and down. So this is the normal person. This is the person between 18 and 35. And you can see they have a regular pattern to their hormones. There may be a slightly bigger gap between here and here than there is between there and there, but that's it. They have a regular gap like that. And just a few words about the progesterone. It prepares the uterus in particular for pregnancy, and that's what we saw in the second half of the cycle, it rises. But if the egg is not fertilized, the corpus luteum breaks down, the production of progesterone falls, and a new cycle begins. And that's just to remind us there, you can see the progesterone is maximum there. No pregnancy is recorded, so then it falls. Now, and we've covered some of this already. The FSH stimulates ovarian function and tries to get the estrogen level to rise. And when the estrogen level rises, the FSH falls, and then the LH level starts. And the LH levels, these levels are all low in the menopause. So there are 3 different ways that migraine is affected with menstruation. And this is in the an international classification of menstrually related migraine. It's in the appendix. And usually when something is in the appendix, the research in this area is not extensive. And it highlights the need for more research. So you can have menstrually related migraine. And attacks occur in that case in 2/3 of the time during menstruation, but they can occur at other times. Then you have pure menstrual migraine, and it's present in 5 to 15% of women. So it's not the most people. And the migraine attacks occur between -2 and +3 days. That's 2 days before the period and the first 3 days of the period. And it's typically migraine without aura. And then you have non-menstrual migraine, meaning that your migraine is not affected by menstruation at all. But before you can say you have any one of these conditions, you must have 3 months of your diary, and you must be able to show it to some medical person to try and get an accurate diagnosis. Now, a few words about pure menstrual migraine. As I say, it's only present in 7 to 15%, and it's the fall in the woman's estrogen level just prior to menstruation is the trigger. No migraine aura, and men, just to say, don't have this trigger. But I would like to just stress a few things. I know my colleague Esther Tomkins talked about triggers last week. And if you look here, stress triggers migraine in almost 80% of cases, and the migraine is in 65%. But I always like to point out almost 60% of migraine is triggered by not eating. And that's very clearly something we can do something about. We can definitely do it. And while we're on the diet and the eating, cheese, chocolate, and red wine are now considered to be cravings in the aura phase rather than migraine triggers. They're no longer considered to be migraine triggers. So we go back and focus on the pure menstrual migraine and the ordinary migraine. Why I'm making such a big deal about it is because those with pure menstrual migraine, the attacks are more severe and of longer duration. And sometimes the regular acute treatments like sumatriptan, which work usually pretty well, do not work well in pure menstrual migraine. However, I am glad to be able to tell you that frovatriptan and naratriptan are longer acting triptans and usually work quite well in this type of migraine. So it is worth maybe chatting to your doctor and saying, yes, you've heard that some of the longer acting triptans, are better placed to help you if you suspect you've pure menstrual migraines. And the other difference is female hormones. Taking the female hormones may work well as preventatives rather than the usual preventatives. Now, I'm not suggesting for a minute that you stop your usual preventatives, but you might add in the female hormones, and we'll discuss that in detail. So what you're really trying to do with pure menstrual migraine, once you have the proper diagnosis, is you're trying to stop the hormone level changing every month. And what we recommend is progestogen hormone. And the progestogen only pill has been on the market for several years. And it's safe to take whether you have migraine with aura or whether you have migraine without aura. Now, there is one, it has to be this particular progestogen only pill, desogestrel, because you take it every day, there's no breaks, it suppresses ovulation. Now, it does have side effects, and I know that the migraine people are very sensitive to side effects, and it can cause vaginal bleeding. And sometimes if you have excessive vaginal bleeding in the first 3 months of taking this, you might increase the dose, or your doctor might increase the dose to 2 desogestrel tablets, 300 mcgs daily. And of course, if you increase the dose of desogestrel, it even helps the migraines all the more. You could opt for an injection, the longer acting progestogen injection, or the implant, which lasts 3 months, commonly known as the bar. And while this approach is particularly important for pure menstrual migraine, it may also help those with menstrually related migraine. So a few other options, the non-steroidals, and we'll come to them at another stage. Ibuprofen, naproxen, they help period pain as well as helping the migraine. And they're often recommended in acute migraine. So what we might suggest is, and I know in the UK they suggest this in their guidelines, that you might even take a naproxen and a triptan the night before the period is due. Or you might take the longer acting triptans, or you might increase your regular preventative medication just before menstruation to see if that might help. Some women come and they tell me that magnesium from the time of ovulation until menstruation is really good, and it works very well. Now, there is no evidence, there's no strong evidence for this, no clinical trials, but this is what people do tell me. And I just want to say a few words then about lifestyle. We want the unstranging stress, and I suppose that's the most difficult thing of all, given the times we're living in at the moment. But we could think about the unchanging female hormones, and we could think about the regular meals. And my colleagues in the headache world internationally stress that you must have your breakfast at home in the morning. Having the tea at 10 o'clock is not adequate. You must really get up that extra half an hour earlier and have the breakfast and drink lots of water. And I do like to say about stress is, not all migraine is stress. And so often we hear that, those who suffer from migraine, if they didn't do this. But I think any migrainer trying to get up at 4 a.m. for a holiday flight, or the night feeds, or working at nighttime like our nurses, our security people, they just have to forget it. They just cannot do it. And surely that's not stress. Just want to say a few words about those people who are taking the combined oral contraceptive. That is the one with the estrogen and the progestogen. They usually take 21 tablets till day 21. And then from day 21 to day 28, they're taking none. And you can see the hormone level drops here. So the worst day for migraines to come is day 3 of the free, when you're taking your pill-free time. So day 3, and that coincides with the drop in estrogen really getting through you. In fact, some people would recommend that really migraine people should take progestogen only rather than the combined oral contraceptive. And this gives you the monthly variation in the way your hormones are and how they go during this time. So another option some people might do is, how would you keep the female hormones from changing? Well, instead of taking the packet, just one packet with 21 tablets, you could take 3 or 4 packets and take no break in the pill. And that would keep the hormone levels stable. However, after the week's break, you could then go back and take 3 or 4 more packs continuously. But I'm sure you're at a high risk of getting a headache in the pill-free time. However, that's really the time to work on your other triggers, because as we've all seen over time, it's not just one trigger, it's usually a few triggers all at the one time. So let's discuss now the perimenopause, and it's the transition stage in a woman's reproductive life that begins about 4 to 5 years before the menopause. And it's during the perimenopause that the estrogen levels are fluctuating. And is it worse than the menopause? Yes, unfortunately. So really the menopause is not so bad, because with the menopause, your hormone levels are stable, but the perimenopause is really the difficult time. And this will give you an idea of how your hormones vary over a 6-month period in the perimenopause. You can see there's no regulation on them. They're really all over the place. And by comparison, this is the hormones for those between 18 and 35, and they're as regular as clockwork most of the time. So the FSH is raised in the perimenopause, and as we've discussed before, it's trying to raise the estrogen level. But of course, in the perimenopause, the estrogen levels don't rise and the FSH remains up. And this raised FSH level causes the hot flushes. So if your FSH level is greater than 30 IU on 2 different occasions with blood taken 6 weeks apart, and you haven't had a menstrual period for a year, it's generally accepted that you've reached the menopause. And in fact, this would be your goal. So what are the signs of the perimenopause? Well, it begins with irregular menstrual cycles due to declining ovarian function, and then ends 1 year after the last menstrual period. The length varies from one person to the other. It can last 3 to 4 years, or it can last as long as 10. The cardinal signs are the hot flushes. By the cardinal signs, I mean the main really important signs are the hot flushes, the heavy, light, irregular periods. For some, the periods may just drag on, but for others, they end abruptly. And some of them really are very heavy. So the hot flushes and the night sweats are really the signs of the perimenopause, and they are due to the decreased estrogen levels in association with a raised FSH level. And what's happening is, in your brain, the body's thermostat is telling the body that you're actually quite cold, and it the body's thermostat is telling them that you're quite warm, even though you mightn't quite possibly be, and it sets off a chain of events, a hot flush, to cool you down. After the perimenopause, hot flushes can still occur and can be precipitated by hot foods, caffeine, and alcohol. But the hot flushes are particularly bad in the perimenopause at nighttime. Wake you from your sleep, you're throwing off the covers, putting them back on, and your sleep is totally disrupted. So if you have these symptoms, the hot flushes, the night sweats, and the dry vagina, they're really the symptoms of low estrogen. As I said previously, there's less specific symptoms like the poor sleep, the mood changes, the weight gain, the breast pain, joint pain, headaches, concentration. But they're not as important. They're not the real important symptoms that one goes on if you're trying to decide if your estrogen level is low. So what happens to migraine in the perimenopause? Well, I think you can probably guess the answer here. With the fluctuating hormones, the dropping estrogen levels from baseline, they're so erratic, the migraines worsen. And then, of course, you have the hot flushes and the poor sleep and the mood swings, and that makes things even worse again. And then you're more likely to have coexisting disease like blood pressure, anxiety, depression, sleep disturbance. So everything is kind of working against you in the perimenopause. So really what you've really got to do, you can see there's a lot of work to be done, and you really have to look at the things that are likely to make you worse and work on them. So I would think the HRT is a good option for those with the hot flushes, night sweats, and dry vagina. And usually the type of HRT one recommends is an estrogen patch. A gel is also recommended because the absorption with the gel or the patch is more reliable. We tend not to advise the tablets, but certainly if there's for some reason you can't take the patch or the gel, then they're an option. For people who have a uterus and are getting hot flushes and still have their uterus, you may have to take progestogens. And there is a vote to tell them take them from day 14 to 28. But for those who have migraine, we recommend to take them daily. And I think that's something as well to go back and discuss with your doctor. However, we don't recommend HRT in the perimenopause if it's just frequent migraines. If you haven't got the hot flushes, the night sweats, and the dry vagina, HRT is not recommended. Other things that can be done at this time is we discussed the progestogen only pill, and you could take that because it will stop ovulation completely and you might find it useful. The injection is also an option. But one thing to remember at this stage of your life is that if you're 45, 50, it might be wise, or it is recommended, that you have a baseline DEXA scan to look at the bones before you go on the progestogen injection. Excuse me, I'll just get a drink here. Now, as I said earlier, there are other migraine preventatives. And it's important not to stop your regular preventatives. And the beta blockers and the candesartan, they help blood pressure. So it's important to get the blood pressure checked. The topiramate is also very good for migraine. Amitriptyline is great for sleep. So if you're having the hot flushes and the night sweats, perhaps some hormones and the amitriptyline might be good. If you're troubled with anxiety and worrying about teenagers and elderly parents and have maybe a little depression, then venlafaxine is absolutely ideal. And we have newer drugs, the CGRPs, which are showing good promise for migraine in all sorts of circumstances. Unfortunately, they're not freely available in Ireland yet, and the plan is that they will become available in specialised centres only. As we mentioned, it's important to keep the blood pressure normal, and sometimes there's been a recent survey or a recent research has found that sometimes the menopause symptoms and the blood pressure get mixed up. And in fact, the blood pressure is raised, and sometimes doctors say, oh, it's just the menopause. So be sure to get your blood pressure measured. A walk early in the morning is really good. It helps to reflect the natural circadian rhythm and to, increase your natural melatonin level. Now, we're all using computers a lot more with the advent of COVID, and I think it might be wise, if we heard from SIVE at this stage, from the Migraine Association, because they have some very useful work. They've done some very useful work in getting information about this, and I'll just pass you over to SIVE for a few minutes.
Thank you very much for that, Mary. And yeah, you're definitely correct with everything in the past year that has been COVID-19, which has seen, us working from home, studying from home, homeschool. And there's definitely been a lot of change for us to get used to when it comes to migraine management. And one thing I do always recommend is, you have good posture. And if you're sitting at your desk or a computer, I know for a lot of people in the short term, we were working with laptops sitting at our kitchen table, but over time, that's really going to affect our posture with our neck and our shoulders and create tension. I highly recommend taking regular breaks from your computer screen. Even if it is just to look away out the window or focus on something that's not a computer screen or a phone screen, just for a few minutes, even, every 30 minutes, 20, 30 minutes, take that break. If you have a lot of classes or meetings via Zoom and Teams, and even just turning off your camera and face away from your laptop or computer, and treat it as a phone call, and just to give yourself a complete break from that screen. For some people, I know they use tinted lenses and sunglasses. One example would be Perspex. You can also fit anti-glare or blue light filters over your screen, which may help. I know the f.lux is one example of it. There are apps you can download for phones or tablets that will help filter out the blue light also. Turn off lights overhead if possible. The fluorescent light or the LED light can contribute to your migraines. I would also sit in an area where I'm not facing a glare, especially with the nice bit of sun we're getting. Just be sure you're not sitting directly in that glare and looking at a computer screen, because that'd be quite tough for you. And as Mary said, do try and take those small breaks and go for a walk and stretch. And, before working from home or schooling from home, we were up in the morning, walking out to the train station or walking to work and getting lots of breaks in, which we're lacking at the moment. I think now we are very much get up in the morning, go down, put the kettle on, turn on the computer and start work. So I would encourage you to get those small little walks in and stretch breaks in. Remember to eat regularly, keep hydrated, make sure you're drinking lots of water. And for some people I know, working from home, you kind of lose your routine that you would have had in work and your lunches, or if you're studying a lot for exams coming up, and you need to remember to eat regularly and, eat relatively healthy, not just convenience or quick food. So even setting little reminders on your phones or little alarms when to take a break to eat something and drink water. Try to keep to a study routine or a work routine and keep it even and regular, so you're not cramming too much, especially, you come to month end and work and it's really, really busy. So we try and get a routine going where we can evenly distribute that work. And you can visit our website, migraine.ie, and we do have a whole piece on visual stress, light, and migraine. And I would just pre-warn that people that are sensitive to lights, and there are some images on it that can be triggering. So just be careful when you're scrolling through. You don't go through it too quickly. But yeah, I'll hand you back over to Mary.
Well, Saif, that was great. Thank you very much. And really, I think there's lots for us all to learn there. And it's so important to take breaks and to eat properly. And lastly, the last thing we can do is yoga. Yoga really slows your heart rate, the respiratory rate, and it helps your reaction to stress. And given that 80% of migraine can have some stress as a trigger, you know, I'm sure it's a good idea to do it, and it has worked very well for people. The Migraine Association over the years have had somebody give classes in yoga, and I've attended some of those, and they're really, really helpful, and you know, just give you lots of food for thought. So we kind of have covered this already, that the menopause is the absence of menstruation for 1 year, and you're usually about 53 when it happens. And the good news is that 60% to 70% of those women with migraine improve. And particularly if you're in that category that we talked about, pure menstrual migraine, but that's not all women. This reflects the hormones in the menopause, and they're stable because it's those changing hormones, and particularly when they're fluctuating badly, that really cause the trouble. And this is just to remind you of what happens at other times in our lives. So what happens if you have a hysterectomy and the ovaries remain? Well, your hormones are still going to fluctuate because you remember the FSH is produced in the pituitary and the ovaries are producing the estrogen. So you still could have the hot flushes and the night sweats. But it does take some time for it to settle down. And quite often, hormone replacement therapy is recommended for those with a hysterectomy, even if you have migraine. And if the ovaries are removed, well, I'm afraid you've a really sudden drop in your estrogen level, and 40 to 70% of women worsen at that stage. Because it doesn't block this pituitary axis, you're still having the FSH. So it can be quite bad, and there again, HRT is generally recommended. And as I said before, when one is having the migraine, don't forget your triggers. You kind of feel guilty that you've done something to bring on the headache, and this is not necessarily the case. But it is important to try and take the meat, to eat properly, drink properly, and try and minimize the other risk factors insofar as you can. So if you go on the HRT and you've never had migraine, what can happen there? Well, as you can see, there's 3 different things can happen. There might be no change, you might worsen, or you might improve. So basically 75% of the time, things will be good. Migraine is usually judged over a 3-month period. So if you get a headache the first time you take a tablet, you might think twice and you might try and stick with it for at least 3 months, if at all possible. And obviously the diary is the single most important thing to do. If you haven't got a record of your headaches before you go on the HRT, it can be very difficult to judge it. It's very difficult to remember. So we'll just summarize. Continue your usual preventatives. We'll try and stabilize the estrogen levels with progesterone-only contraception or the HRT. Look at your general health, your blood pressure, anxiety and depression. Look at the triggers and avoid eating regularly. Avoiding high GI foods. You don't want the quick sugar rush with the bananas and the sweets. You want the slice of bread if at all possible. And Saif has given us lots of information there about looking at computer screens and what to do and use of glasses. Exercise daily and consider the yoga. So just a couple of things people ask over the time is, are there treatments that don't include hormones in the menopause? Venlafaxine, which we've already spoken about, and escitalopram. Venlafaxine is good for the headaches and it's also good for the HRT. The escitalopram doesn't work as well for the headaches, but if venlafaxine can't be taken for some reason, there's a second one. And, you know, we've had this question as well. We've covered this one. Can the symptoms change at the menopause? And the answer is yes, they can. And as we saw very early in the presentation, the migraine can maybe present just before the menopause for the first time, or it may have a different, it may just present or change differently. Now, I've specifically left this till the end. The progestogen coil affect migraine, and the progestogen coil is better known as the Mirena. And unfortunately, no study has been carried out in this area. And it's an area of particular interest in. And I have discussed at length with the European experts, and they really don't agree on it. So for me, my experience is that it makes migraine worse more often than it makes it better. But as I said, some of the European experts don't agree with that. So acute treatment. Well, we'll deal with acute treatment in a different module, but it's usually pretty much the same as you would take for any migraine attack. And Martin Ruttledge, Dr. Martin Ruttledge, my medical colleague and headache neurologist, will be discussing preventative treatments on the 31st of March. I always like to include this from my colleague, Dr. Ray Forbes in Belfast. I mean, he's looking at a sensible approach to migraine and trying to do it on a budget, because we all know that when you're not working and you haven't got medication and you can't afford it, it's difficult. So the exercise comes in really quickly there. Even to continue to move your neck and your shoulders, perform relaxation techniques. And, you know, the yoga here is a cheap alternative. And maybe use the aspirin, the ibuprofen, or the paracetamol. I wouldn't say stop the triptans and the non-steroidals all the time myself. I think I'd have a few of them in the press just in case I got a bad attack. So thank you very much for your attention, and thank you for all the questions. And thanks to the Migraine Association for asking me to speak. And if you have any further queries or comments, I'll be happy to address them.
Thank you very much, Dr. Kearney. It was a pleasure to listen to you speak as always. For anybody, you can always contact the Migraine Association of Ireland. I'll share our contact details here and we'll be able to respond to you. And just to note for everyone that this talk and any of our talks are all for information purposes only. It's not to replace medical diagnosis or advice. And please don't change any treatments you're on before consulting with a healthcare specialist. But thank you all for joining us.